Hello, everyone, and welcome to our live event tonight. It's good to be back. It's a Monday evening, and I'm very happy to be back here with Dr. Luca Gianaroli. Hi, Dr. Luca, how are you feeling today?
Thank you. Very well.
Happy to
Ready
hear
to
this.
share.
And we are definitely excited to have you back as our presenter. This is our second Stronger Together edition, and of course, Dr. Luca was took part in our first Stronger Together edition. So happy to have you back indeed, and thank you already for joining us and also for bringing this topic to us as well. And we will start with Dr. Gianaroli's presentation, and afterwards, as always, it'll be time for your questions. I do see that you have already typed some questions in, so Dr. Luca will definitely answer them right after his presentation. And let me just remind everyone that we are here every single day to support you, to give you some tips, but also advice, and provide you with as many details as we can to simply um, just simply be here for you, because we know those times nowadays are not so easy. And well, I would also like to thank to our ambassadors and partners, as always, for their support, for simply joining our Stronger Together initiative as well. Thanks a lot for that. And as I've mentioned, we will start with Dr. Luca's presentation. And our topic tonight is how to make IVF treatment successful after failed attempts. And this is our kind of main topic when it comes to this edition of Stronger Together. So, as you can see, of course, Dr. Luca is from CISMER, which is a reproductive medicine institute located in Bologna, Italy. And Dr. Luca is the scientific director of the clinic. So, thank you so much once more for joining us tonight. And Dr. Luca, are you ready to start with your presentation?
Yes. First of
Wonderful.
all, good evening. First of all, good evening to everybody. How to make IVF treatment successful after failed attempts? Well, the answer could be easy. Just don't fail any attempt, and that's it. And you will have an IVF treatment that is successful. If this is not possible, another way to look at the problem is don't do IVF attempts. It means, can we do some prevention before failing IVF attempts? And if we look at the factors causing infertility, they range from genetic factors to congenital factors to acquired factors like infections or disease or general disease. And I like to remind you that from BMI to diabetes to other disorders, they can impair your fertility, down to aging. So different causes require different solutions in one way or in another. Prevention is better than cure, and if it's possible, prevention is better than do IVF cycles and fail. The first step is don't wait too long before seeking medical advice. If you are ready for a baby, then of course we need a comprehensive diagnostic workup for patients and partners to be sure that ART and related techniques is the option that we need to use for the best treatment. But if you are not ready yet for baby, I think that fertility preservation or social freezing, mainly for females, is probably the most effective way to avoid failed IVF treatment. Let me just spend 2 minutes on this. Fertility preservation is a cryopreservation of ovocytes for medical or non-medical reason for a future use within an IVF treatment with higher success rate, because your age is the age at the time of oocyte collection. When is the right time? At any time, as far as before the age of 35. For better outcomes, this is the age that is recommended to have success rates that are higher than you can expect. Of course, you can do it after 35, but then you have to realized that maybe more than one oocyte retrieval may be necessary to collect a suitable amount of oocytes. And of course, we also have to remind that success rate of a subsequent IVF treatment may be lower than expected. Why this is so important? If we look here at the age of the female patients below 34, 35, 37, 38, 40, and so on, you see here the proportion of oocytes that are impaired. So they are aneuploid, they are carriers of a number of chromosomes that is not correct. So when you have an oocyte that has incorrect number of chromosomes, the chance to deliver a baby is dramatically low. And as you can see, at the age of 41, 43, one oocyte out of 7 or out of 8 is still suitable for delivering a normal, healthy baby. And you can go down or up, whatever you want to see, to 96% over 44 of aneuploid oocytes. So oocytes that are not usable for IVF and related techniques. So these techniques will work very nicely when we still are below the age of 35. So it makes sense, if there is a reason to postpone pregnancy, first of all, to reduce the risk of unsuccess, just cryopreserving your fertility. It goes through preliminary medical tests, an ovarian stimulation, a surgical oocyte retrieval, and then to cryopreservation. And the more oocyte you cryopreserve, more chance you have to deliver a baby if there is a need to use this. If this is not possible because you didn't approach the problem from this corner, then we have to try to manage IVF failure when they will occur. There is one thing that is extremely important. Never give up unless you are sure that there is nothing else that you can do, or unless you are sure that you had the right advice. So seek for medical advice. It means to try to realize that your choice of the medical advice is the right one. And that implies suggestions or recommendations on treatment repetition, PGT for aneuploidy, endometrial receptivity test, or an gamete donation. If you fail one or more attempts, and if these 4 options have not been checked, you should not give up to your treatment. Having an unsuccessful IVF means to have a failure of implantation. And you can have a failure of implantation because your embryos are rest, because your embryo implant, but you have an early pregnancy failure, and because embryos do not implant even if they do develop normally. So you have to understand very clearly that your success is really at the end of your route, and before it there are failures, potential unsuccessful cycles, and until you don't find the right way, you have more difficulties to get what you are really looking for. But again, don't give up unless you really are convinced to be at the end of the road. There are a lot of reasons why recurrent implantation failures can happen, and these reasons are so many that we can even think about a group of patients where RIF, recurrent implantation failure, happens, and this characterizes the specific need for these patients. The major problem is that this group of patients is an heterogeneous population, because there are many factors that are involved in repeated IVF failures, and they are different. They go from immunological reactions to karyotypes that is altered in one of the partners, not necessarily the female. We could have endometrial anomalies. So uterus look normal, but the endometrium has anomalies. There is an important factor related to sperm contribution. So even the male factor play a role, and it doesn't really matter if the parameters of the analysis of the sperm look normal. There could be something more subtle. The genetic factors can affect the competence of the ovocytes and the competence of the male gamete. While advanced maternal age, as it was mentioned before, is crucial to reduce the possibility of full-term pregnancy due to the increased number of chromosomally abnormal ovocytes. On the top of this, we can have uterine abnormalities, and if they are not diagnosed, and some of them are difficult to diagnose because they are subtle, once again, the failure of repeated cycles can occur. Furthermore, there are systemic problems that could range among several disorders, but the most important or the most frequent could be defect on coagulation, something that very rarely patients relate to the failure of implantation. But if a patient has coagulation defects, the failure of implantation on early miscarriage can occur quite frequently. I want to focus because I think that the most important thing is the information for patients. If patients understand clearly some of the physiological mechanisms, even if they have not a degree in medicine or they are not specialists in reproductive medicine, they still can go side by side with their clinician to remove those potential causes of implantation failures. The system of implantation, the beginning of pregnancy, the development of full-term pregnancy, it has two faces of the same coin. From one side, the endometrium must be receptive. That means uterine anomalies should not be there, coagulation defects should not be there, endometrial anomalies should not be there, and immunological reactions, even if they are rare, should not happen in that specific individual. The other side of the coin is an embryo. The embryo has to be viable. That means that gametes have to be healthy gametes because their contribution is very important to the formation of a normal embryo. The embryo must be able to develop normally, and then if IVF is performed, so if not a natural conception occurs, the conditions of the lab and the in vitro culture is crucial to generate an healthy embryo. Furthermore, the procedure of embryo transfer can also play an important role when patients are ready to receive their chance of pregnancy, having an healthy embryo transferred to the uterus. Let me just have a look to some data that can explain to you how important is the repetition of treatment. We are using since many years a program that is called IVF Light, that is a very light regime of stimulation where we guarantee to patients free embryo transfer. Doesn't matter if they have been generated by fresh embryos or they are thawed embryos that are going to be transferred. If the patients allow, in principle, to have free embryo transfer, and if we look at our data without spending too much time in terms of looking at the table, but at the end of the day, in young women, this is the age, the average age of our patients in this study. You look at a limited number of oocytes have been retrieved, but when you look at these couples that ended the program, and we are talking about 358 couples, they underwent a total number of 800 800 embryo transfer and we look at full-term pregnancy, we see that out of these 358 patients, 235, that is 66%, they delivered before the end of the program. That means before or a maximum of 3 embryo transfer, transferring 1 embryo at a time. In fact, if you look at the program here, this is the percentage of patients who delivered after the transfer. All the remaining non-pregnant patients came back, and another percentage of them became pregnant and delivered. The remaining, less than 50%, went back for a third transfer, and again another slice of full-term pregnancy have been achieved, showing like in 3 embryo transfer, pregnancy and delivery, that is most important, is achieved in almost 3 patients out of 4. So please don't give up unless there is a good reason to do so. If you fail 3 normal IVF attempts, that means for us 3 normal embryo transfer, the concept of selecting embryos for aneuploidy screening has a very simple concept. It's removing, if it's possible, those embryos from the reproductive circuit that would never implant. So avoiding the transfer of abnormal embryos, it's possible to reduce implantation failure and miscarriage, the cost of treatment, and what is more important, reduce the time to a full-term pregnancy. So PGT for aneuploidy could be a tool that can be used. Without going into too technical details, I want to show you something that is really interesting. These are 3 studies, 3 authors. Numbers are not very big, but these studies are very well designed. They are randomized studies. One is in America, transferring always 2 embryos. One is again in America, using a different technique of aneuploidy screening, and one is in Spain. When you look at the control group versus the group in which PGT for aneuploidy is done, the difference is statistically significant. Here, where Scott is very aggressive in transferring a large number of embryos, but is still statistically significant in young, and is still, with different results, statistically significant in Spain. What is more important, and what I would like to say, is that here, the difference between the control group and the study group, where PGT for aneuploidy has been done, is that 14 deliveries have been missed in the control group. Here, 13 deliveries have been missed in the control group, and here 15 deliveries have been missed. The calculation I want to show you is how many conventional cycles in Scott group should be done to reach these 14 deliveries that have been missed in the control group. Since Scott program has a very high performance, as you can see, they only need 21 conventional cycles to reach those 14 deliveries that have been lost in the control group when PGT has not been done. Here, in young, where the performance is lower because it's transferring less embryos, to get these 13 deliveries that are missed in the control group, 31 conventional cycles are required. And when you go to Rubio, where 15 deliveries have been missed, but the percentage of full-term pregnancies is lower, you need almost 100 cycles to get these 15 deliveries that have been missed in the control group. So PGT for aneuploidy is not going to make your genetic material better. It just shorter the time to pregnancy and, of course, reduce the burden, the stress, and the cost of your treatment. Or it can give you an answer that is, all your embryos are chromosomally abnormal, and then you have to think to change and to shift your program. If you have few failed attempts you should really look to your window of implantation, so to your uterine potentiality to accept a normal, healthy potential blastocyst to implant. There are many tests. I'm showing you this one because it's a test that is probably one of the most efficient and one is the cheaper. They've selected 67 genes and the accuracy is quite good because it goes down to single molecule and the cost, at least in Europe, is around 400 euros. So biopsy is done during a month cycles, and then the full sequencing is done with the aim of selecting the 67 genes that are involved in implantation. And you end up with this sort of information. You can detect the receptivity of your uterus that is expressed as a score, what is called a receptometer. And you can have three scenarios. Your uterus at that specific day is pre-receptive or non-receptive. It is completely receptive or is in bracket too old, so is almost post-receptive. According to this data, you can, in the real transfer cycle, postpone the time of transferring your embryos, anticipate, or just doing nothing because the treatment is obtaining what you are really looking for. If we know that gametes are completely damaged and the number of non-damaged gametes, both oocytes or sperm, is so limited that is almost anecdotal to reach a pregnancy with these gametes, then we should think seriously to the donation of gametes. Sperm donation is useful in azoospermia, and this is quite rare when there is a congenital or medical causes like chemotherapy, lack of spermatozoa. When we have sperm chromosomal abnormalities, as I was mentioning before, when chromosomal or genetic disease in the male partner occur, when we have infection disease that have destroyed the potentiality of the individual sperm. So again, sperm donation is an option, as it is an option oocyte donation. When the quality of the oocyte is very low because there is a primary ovarian insufficiency, or there is no chance to get an oocyte, like in premature ovarian failure or in menopause, or when the female partner has chromosomal or genetic disease, they can still produce oocytes, but their quality is extremely low. Also, for very poor responder patients, an indication for oocyte donation could be due to the fact that few oocytes of scarce quality could impair the success rate. When we fail many IVF attempts, the uterus is receptive and the embryos seems to develop normally, but PGT is showing that these embryos do not implant because of chromosomal aneuploidies. It's time to think about an oocyte donation. And it is a time to think about an oocyte donation as recurrent miscarriage, mainly over the age of 40, happen or frequently happen. If we have an impaired ovarian function due to chemotherapy or surgery due to endometriosis, we have another option to look for oocyte donation. As far as we have another option to look at this program when infection diseases are modifying the quality of the oocytes. So my concept is don't give up, keep going, but have an eye. Keep going doesn't mean repeat and repeat and repeat without having an idea of what is happening. Keep going mean keep going to look for better diagnosis, for more difficult treatments, for more personalized treatment. This is the way in which ART and related technique will be helpful for you, or for those of you that should be considered as difficult couples since they failed few times IVF success. I would like to stop here and maybe to answer to some of your questions, if any.
Yet again, interesting presentation, lots of useful details, no doubt here. So thanks a lot for that. And you are very right. It's time to start with the questions, and there are plenty of questions ready, in fact. So I guess we can go ahead with the very first question that we have right here. I have just completed my first cycle of donor egg treatment, which ended in failure. I have a follow up meeting with the consultant in Spain this week. Is there any questions I should be asking regarding changes to my next donor egg cycle? I am on a pregnancy guarantee program. I am 45.
No, you shouldn't be too worried because you shouldn't forget that a part of the program in which you have a guaranteed pregnancy, one embryo transfer has to be considered from the physiological point of view, like you being a fertile, normal young woman having an intercourse with a fertile man. If pregnancy does not occur, you are not surprised too much. So here you are comparing the same thing, and you should have, before being worried, at least having another or two other attempts.
And wonderful. Thank you so much for your very first question, and of course for your answer to that very first question, indeed, as well. Let's have a look. Of course, there are many more questions coming up, and let's go to the next one. Hi, I have had 3 failed rounds of donor egg. I am 33 and really starting to lose hope. I have requested PGS testing on my remaining 4 embryos. Is there anything else I should be doing? My clinic says it is an implantation issue.
I also agree with your clinic. It's possible that it's an implantation issue, and for this reason, the test I just mentioned to you, something similar, should be used before you go for another embryo transfer. So go for an embryo receptivity, an endometrial receptivity test first.
All right, understood. Once more, thank you so much for that advice. And let's have a look. More questions are here. I had an early miscarriage from my first IVF cycle. I'm 44. I had donor egg, had PGD testing and microchip. I have an autoimmune disease. I have been told I will be on immune therapy next time. Is there anything else I should consider for my next cycle to help improve my chances?
No, what has been suggested and recommended to you is the right way to go.
All right, thank you so much for that, indeed, as well. And next question is 41 had 5 natural miscarriages in 18 months. Did IVF with PGT. 3 embryos made it to blastocyst and all tested normal. 1 embryo put back but failed. Is there hope for the last 2 embryos? What other tests should we do? Done all standard fertility tests and all normal with both of us.
Yes, I think that if hysteroscopy has not been done, it should be done in the just after the period, while a 3D ultrasound should be done in the luteal phase, so just before the menstrual period appears. It's important to understand properly if your uterus is ready for an implantation. So I would not be worried about the endometrial receptivity, but I would be happy to see the cavity of your uterus since it has been already damaged by the first 5 natural miscarriage.
And wonderful. Thank you so much once again, of course. And next question is up. How badly can TSH serum level impact the transfer success? I started with TSH of 5.1 approximately 3-4 months ago, but latest test showed 0.17 and the healthy range is 0.52. I am supposed to have third day fresh transfer on Thursday, assuming my embryos survive. Doctor recommended to skip my levothyroxine 75 milligrams daily next couple of days and repeat the test on Wednesday. Anything you can advise?
No, I think that it's well, there are not enough data showing that TSH low level are crucial for implantation, but the range 0.5 to 2 is now a well accepted range, and anything that can be done modulating or tuning the treatment, the therapy, the thyroid therapy, or anything that could help to maintain these values is the most important thing. So I think that to skip the drug, as it has been suggested, is correct because actually your TSH level look like to be too compressed, and that's maybe stopping the treatment for a few days will make your TSH level to increase and reaching the normal range. So I am in favor of this decision.
All right. Once again, of course, thank you a lot for that recommendation as well. Let's have a look. Okay. Next question is also up. Thanks for your positive encouragement to keep on going. Very reassuring. I have had one round of IVF with failed implantation, looking to have another round in January. Prior to IVF, I have had day 3 hormone blood test and day 21 progesterone blood test. TSH blood test and scan, all results were normal. I've just turned 42. Would you suggest any other pre-test before I have another round of IVF?
Is if no pregnancy have occurred before, and if your uterus never had a reproductive accident, miscarriages or termination of pregnancy or so on, no. Otherwise, hysteroscopy is recommended. And don't forget that at the age of 42, your chance to delivery is around 12-15% per embryo transfer. So if you want to have a decent percentage of full-term pregnancy, you should enter the concept that you need 5-6 embryo transfer if you want to use your gametes. The fact that you had a pregnancy 12 months ago is encouraging because it shows that your body is ready to get pregnant. Having an ectopic, I don't know if they have been generated by IVF or if they were natural, anyway, could also show an inflammation of the tube and a small malformation of the uterus. So it would be nice before you enter another cycle to double check your uterus and your uterine cavity.
All right, of course. Thank you once again, of course. I just wanted you to see that, of course, Karen has added some information. So natural pregnancy and ectopic resolved naturally.
Okay, fine. So that is even more important to check the uterus. And it has to be done with double test, 3D, ultrasound, and hysteroscopy.
And wonderful. Thank you a lot again, of course, here. Okay, next question. Short one. Would you recommend growth hormone?
The only reason why growth hormone could be recommended is if you are a poor responder, because apparently in some subgroup of poor responder patients, growth hormone seems to be of some benefit in growing more follicles. That means more ovocytes to be collected.
All right, again, excellent. Thank you so much for that. Next question. Thank you for the presentation and your kind words. I am close to breaking point. I have had 3 cycles and only 2 embryos. My last cycle was fertilization failure due to egg quality. I just turned 40. Should I just give up or should I try something else? I didn't get an embryo to PGS test. AMH is low. Is donor or adoption my only 2 options?
Probably to say that they are the only 2 options is too drastic. But if you want to look in a pragmatic way to the chance you have to deliver a baby, if you use your own gametes, your chances are really extremely limited. It's a combination of your age, your AMH, and most probably to what your body has been designed in terms of conception since you were still inside the womb of your mother. Maybe you started to have periods quite early. Maybe somebody in your family had an early menopause, your aunt, your mother, your grandmother, your older sister. Anyway, you look like that your age is different from your biological age or from the biological age of your ovaries. So most probably, if for you and your companion um, a baby is not a complete, is not defined as a complete overlapping of genetic material, but if for you a baby is the individual that you are carrying on, that you are delivering, that you will educate and you will accompany during his life, maybe oocyte donation is a good program for you or is the best program for you.
Okay, understood. Of course, thank you once more for that. And of course, as you can see, there are some thank yous, of course, already. I want you to see from the patients that you answered. Thank you. That's very helpful. So, thanks a lot for all the advice so far. And of course, let's go ahead with the next question. I had one fate transfer back in July. It was potentially due to a polyp being discovered during a baseline scan, but decided to carry on anyway. I've now removed it. Do you think I should check anything else? My lining thick was perfect in July.
No, Alessia, don't check anything else, but recheck your uterus because sometimes polyps can come back. And there is a tendency for patients that have a polyp to repeat the production of this pathology. That is not only a mechanical pathology, but since polyp is a sort of top of the iceberg of an inflammation. Actually, when you have a polyp, the total endometrium can be inflamed, and that implies a reduced chance of pregnancy.
Okay. Once more, thank you so much for yet another question, of course, and your help with that. And we will go back to the previous patient, Karen. She has added another question. Thanks for answering my question about pre-testing after ectopic pregnancy. Should the 3D ultrasound and hysteroscopy be carried out at a certain time in my cycle? Are you able to advise on the approximate cost of both of these tests?
Well, the second part of the question, I don't know because it's very much depending if you are using a national health service or if you are going to a private clinic. I don't know country which you are, so I have no idea and no capability to answer to this question. I can tell you that in Italy, both tests would cost not more than 600 euros in a private clinic and therefore free in a public hospital. Yes, hysteroscopy should be done just after the period, while 3D should be done just before periods.
And wonderful again. Thank you so much for that. And again, we will go back to the previous patient. There is a thank you from Karen, and we will go back to Alessia. Thanks a lot for this answer. How do you know if your endometrium is inflamed? How do you find out, and what kind of test you can do?
The elective way to understand if you have an inflammation is to do an hysteroscopy, but there are now tests that are under progress that can avoid even the office procedure, just producing or aspirating a little bit of fluid that is inside the cavity of the uterus.
All right. And one more time. Thank you so much for that. Okay, and there is another follow-up actually. So thank you, doctor, for confirming that donor eggs are a good option in my position. One last embryo of my own to transfer before we move on. Hysteroscopy and receptive, sorry, I'm not sure, DX test being done prior to transfer. Anything else?
No, just hopes that your embryo has already reached the stage of blastocyst, and then you just cross your fingers.
And definitely, fingers crossed. Of course, there's another information. Day 5, 2AA.
Okay, good. So we hope there is no aneuploidy in this blastocyst.
Wonderful. Thank you so much. And of course, there is a thank you from Alessia from the previous patient to you, and another thank you from the patient. Of course, let's go ahead with the next one that we have right here. 47, a 6-year-old. I had egg donation transfer and failed. I had hysteroscopy last month and I had one polyp removed. I'm going for second attempt of IVF. Lining of my wound is 6.8 and blood result is on the borderline. Do you think I should wait for the next month?
Yes, you should, and you should also increase a little bit the amount of estradiol valerate, because it would be nice that your lining is above 7.
Excellent. Thank you. One more. And next question is a short one. When would you recommend getting immunology testing?
If I have to be frank, I would say when you are desperate, because the chance of getting good results in terms of being positive results from immunology test is quite rare. So you have to be sure that all the other aspects that we have looked at are really negative. So keep this as the last point of your diagnostic procedures.
And thanks a million for yet another answer. Let's have a look. Next question is also ready. I have IBS and hypothyroidism Hashimoto. What can I go to? What can I do to improve implantation, knowing that I am 44 and we are looking into egg donation? Do you suggest immune therapy?
No, I would suggest only to keep your level of TSH appropriate into the normal range, as we have discussed before.
And wonderful, thank you again for that. And again, there is also a thank you from the previous patient. So just want you to see that. Perfect. Okay, next question is also here from Emma. I had a termination at 19, miscarriage at 38. I am now 40, just finished one round of unsuccessful IVF treatment. I have Hashimoto. I will be going through a second round of IVF in January. I am considering a natural round of IVF. Would you recommend that?
No, definitely not, because it's not going to make your ovocytes better. It will only delay and make it longer time to pregnancy. Again, check your uterus and try to get as many eggs as possible. And if you are able to produce many embryos, maybe you should accumulate after 1 or 2 or 3 ovocyte recovery and do PGT for aneuploidy in one shot to reduce the costs. Of course, since two accidents have occurred to your uterus. In this case, hysteroscopy is compulsory.
Again, thank you so much for that. And we do have another question from Karen. Is it possible to have ovulated during IVF and still collect the remaining eggs? I had 7 follicles of varying sizes on scan, 3 collected, and there was no egg collected from the largest follicle, which was a surprise to me. Is this normal or could mean ovulation before collection?
When you have very large follicles that are not online with the others, actually they look like follicle, but they are empty follicles or small cysts with a very limited quality of egg if the egg is collected. You can collect or you can aspirate follicles even if you have already ovulated. But to have good quality eggs, ovulation should have been occurred very recently because otherwise also the remaining follicles containing the remaining oocytes impair the quality of the gametes. So in other words, you will collect not very good quality oocytes.
And thank you again, of course. And again, of course, there are more thank yous coming up. Sorry, let me go to the question from Karen, okay? As this is a follow up. Would it be possible for the clinic to tell if this had happened?
Yes, not with an accuracy of 100%, but it could be postulated. And anyway, if you do a blood sample and you measure your progesterone, this could be also helpful to tell you the real story.
And there is a comment. Good to know. And thank you, as always. And of course, there are more thank yous from the previous patient you helped for, of course, already. Thank you. And there is another thank you. Next question we have. Next month, I am having frozen embryo transfer in native cycle with stop injection of vitral. I have regular cycles and regular ovulations, but usually I have a little bit thin endometrium in time of ovulation, 7 millimeters. What can I do? Would you recommend me using 3 or 4 days estrogen right before ovulation?
Um, you can do it, but I'm not sure that that will help. If you have a tendency to have a thin endometrium, um, I think that you should go for a full artificial cycle, starting with estradiol valerate since the first day of the cycle and carry on with 4-6 milligrams per day.
Wonderful. Again, thank you so much for that. Next question. So, do you recommend frequent monitoring during IVF cycle for higher success rate? Bloods, USG scans, how often is enough? And what blood test monitoring do you think are mandatory? My clinic only did 2 scans and pre-op blood tests.
If you are so-called easy patients, you don't need many monitoring. But if you have already failed few cycles, or if you are a poor responder, or if your cycles are not regular, you need different and several monitoring. You should think about a personalized treatment every time that more than one failure has happened to you. The general concept of all the clinics, it's quite simple. You can divide all the clinics around the world in 2 categories. And this doesn't mean that one is better than another or that one is worse than another. The 2 categories are as follows. The first category is to make everything easy, reduce the stress, reduce the cost, reduce the visit to the clinic. The other group of clinics is a clinic in which everybody is obsessive to monitor more, to get more information from you, to personalize more your treatment. I think that the best clinic is that clinic that is able to combine the 2 previous categories. If you are an easy patient, if the indications are clear, if the diagnosis is properly done, if no failure have occurred before, maybe for you is sufficient a so-called easy IVF. On the contrary, if you are in advanced maternal age, if you had recurrent miscarriages, if you have failed many cycles, if you feel like it's your last chance, if you are looking for something that can give you an answer, the same clinic should perform a personalized treatment for you.
And once more, of course, thank you for that. And if you could take a look at the follow-up, okay, from Patricia here as well. Who is a poor responder? This is my first cycle. Had 10 follicles growing and 5 eggs retrieved.
You are not a poor responder. There is a definition for poor responders that is accepted all around the world and is called Bologna criteria for poor responders. It has been published 9 years ago, and now it has more than 1,500 citations all around the world. The criteria is very simple: less than 3 or less oocytes, age over 40, failed oocyte recovery. So if one of these criteria has already occurred, you can enter the bad category of poor responder.
All right, amazing. Again, thank you so much for that. And there are like a few questions left. We will be slowly finishing. And so if you have any more questions.
So I can prepare my pasta.
Yes, you can. You will be able to do that I guess, in a few minutes. Okay, no problem here. And okay, so let's have a look at the next question. So, what is the cause for thin endometrium? Low level of estrogen?
Well, actually, two major factors for this. One is a morphological situation of the uterus. Let me give an example. If you have leiomyomas or fibromas or fibroids, or your uterine wall is not normal, vascularization is impaired, and this could also play a role on the thickness of endometrium. On the other hand, you can have a perfectly normal uterus with perfectly normal endometrium, perfectly normal myometrium, no pathologies in the uterus, but then the level of hormones is not the correct one. So the endometrium does not respond, or it responds in a pathological way because it doesn't just receive the correct amount of information from the endocrine system. So they can be both, or a combination of two.
All right, understood perfectly. Again, thank you so much for that. And next question we do have ready is: I am 38. I retrieved 10 eggs this year in 3 retrievals and had 0 fertilization. Then I got pregnant naturally but had a miscarriage at 8 weeks. I live in Japan and no options of donors, but what do you suggest I do? I am considering going to Spain next year if traveling becomes easier, but until then, I would like to know what you suggest.
I suggest, apparently, there could be a male gamete problem. So it would be very important for you to perform a FISH test. FISH test is a chromosomal analysis on a certain number, generally a few thousand, of sperm. When you do chromosomal analysis from your blood, you know everything about the chromosomal composition of all the cells of your body: skin, eye, heart, kidney, any organ, but not of your eggs. And that's the same for your companion. If you do chromosomal analysis from the blood sample, he knows all the information from all the cells of his body, but not about sperm. The reason for this is that when you and your companion were 8-cell embryos, inside the tubes of your parents, you already had one cell that has been designed to prepare gametes, sperm for your companion and ovocytes from you. So the only way to know if your ovocytes, or in this case, the sperm of your husband, are chromosomally normal is to check directly them. So a FISH test should be performed using the highest technology with the highest number of chromosomes to be analyzed.
All right. Again, thank you so much, of course, for that advice. Indeed. And just I will show you as there is a follow-up. Okay, is that done in any clinic or at a fertility clinic? Do you know if that's available in Japan?
Um, I don't think that is a routine test done in all the clinics. I visited Japan and I visited few clinics where they are very well advanced. Actually, since the name of the Japanese clinic are very difficult for a European one, I don't remember by memory. But maybe if you write to me, I can give you the addresses of those clinics. Um, I think in Nagajima and in Kyoto that I visited. Well, I honestly I don't remember the names, but again I can check on that.
All right, understood. Of course, thank you so much. We are always able to forward this to you, of course, Dr. Luca, and I'm sure you will be able to also help out. But already, thank you for this as well. And next question is, so what do you recommend I do next after one failed round of IVF? I am 40.
If you in the first round had decent embryos or good quality embryos, you should go for another attempt. If you have quite a large number of embryos, PGT for aneuploidy could be an option to shorten the time to pregnancy.
And wonderful, thank you so much. And well, I guess that it looks like that was our final question. But of course, I just want to mention that if you have any more questions and you would like to get some more details, feel free to get in touch with Dr. Gianaroli and his team. I have no doubt that they will be more than happy to help you. I'm sending you the link where you are able to simply send your requests or emails. This is the way to do it. And Emma also has added that we had three good great embryos as well.
Well, this is a good luck.
All right, of course, fingers crossed for all of you, indeed, as well.
Yeah.
And okay, sorry, I have missed one question, I guess. 3D scan. Just give me a second, okay, Karen. We'll try to find that question. Sorry, just a second, okay? There are plenty of those questions. I just need to find the right one. And in the meantime, you can see, of course, there are more. Okay, sorry. I just need to find it, okay? It just takes a minute, and I guess that would be our final question. It's about the 3D scan. Oh, okay, perfect. Thank you so much, Karen, for that help. That helps a lot. You have no idea. So here it is. I have heard a few times about 3D ultrasounds. Are all ultrasounds 3D? Sorry if this is a silly question. I just don't know the answer.
No, I mean, not all the machinery are designed for 3D, and even if they are designed, the clinician can perform a simple 2D. You have to, I think that in the era of IT and computer, it's very easy to understand that what the 3D does is to construct because of a specific software, the three dimension of the womb and of the uterus. So it's a sophisticated way like a magnetic resonance. And this can help the clinician to check for small pathologies or for small abnormalities. So, if you combine the direct visualization of the cavity of the uterus via an hysteroscopy with a 3D that is designing the thickness of the wall, the potential abnormalities of the walls of the uterus, actually you have a full visions of this extremely important organ that is crucial for the goal in reproduction that you want to achieve. Since it's not invasive or very little invasive, and since it's not painful, and since it's require only 20-30 minutes of exams, I think that is something that should be done.
And amazing. Once more, thank you for this indeed as well. And yes, this is definitely our final question. So thank you so much, everyone, for joining us tonight, for your questions. And it's really great to have you here. I know that you are from very different places, and I'm very happy to definitely be here with you tonight. And Dr. Luca, as always, it's a pleasure to have you. Thank you so much for your help and, of course, answering all the questions from all of our patients. As you can see, there are plenty of comments. I definitely want you to see them as well. They are just simply. Let me just show you, Doctor. You are so very calming, reassuring, and good humor. Thank you for the session. Thank you, Dr. Luca, and of
Well, there
course,
is there is only one message I
yep.
want to pass to all these people that I don't see, I will never probably met, and the message is very simple. Uh, you have the opportunity to use a very powerful techniques to help to reach what you want. Infertility is illness, we know this, and is a chronic disease. So it has to be cured in a chronic way. So when I say never give up, it means you need absolutely to be obsessive in obtaining what you want. That doesn't mean, again, this is very important, that you are blind and you just keep going in doing something that could be wrong. Step after step, explore the opportunity to squeeze this technique as much as possible. You need to have a good clinic, but there are many around the world. But what you need is mainly a good clinician that is able to understand which part of the techniques are the best for you. But you will find them because there's plenty of good colleagues all around the world. Don't give up.
What's better summary than this? Don't give up, right? So, thank you once again for that. And as you can see, everyone is very, very happy that you were able to be here with us tonight for sure. And I can
Good.
only add, enjoy your pasta, as everyone else is saying here.
I'll do.
you
For
you
sure,
definitely
I'll do.
exactly. So thanks a lot. And I just want to remind everyone that, of course, it has been recorded. So you will be able to watch this once again. And you will find it tomorrow on myivfnss.com, but also on our YouTube channel. And we will be back here tomorrow at 7 p.m. UK time. So I do hope to see you. And Dr. Generali, it's always, always a great pleasure to have you here. Thank you so much for joining us again. And I'm definitely looking forward to our next event pretty much soon, I hope, as well. Thank you so much. Take care, everyone.
Okay, bye
Have a
bye.
lovely evening and day wherever you are. Thank you. Bye.
Okay, bye bye.